Welcome everyone to Access Presents today. So I'll just introduce myself. I'm Tamara McDonald. I'm a clinical pharmacy specialist at the IWK in oncology, and I also work for the Atlantic Province's Pediatric Hematology Oncology Network, which we call AFON. And I've been in this role for a couple of decades now. And a real interest of my research is looking at the financial burden to families who have children that are diagnosed with cancer in the Maritimes, and sort of striving to try to improve access to care for these families. So I'll just read out land acknowledgement today. So Access respectfully recognizes and acknowledges the relationship the First Nations, Inuit, and Métis across Canada have with the land all Canadians live on and cherish. As we work to create, implement, and continue this pan-Canadian network, we would like to consider each of the 634 different First Nations communities, 53 Inuit communities, and 8 Métis settlements who have a unique historical, cultural, spiritual, and environmentally sustainable connection to the land that their people and ancestors have inhabited since time immemorial. Access is committed to working to build relationships that include First Nations, Inuit, and Métis peoples. So ACCESS is a pan-Canadian pediatric cancer network advancing childhood cancer experience, science, and survivorship. Our network of researchers, healthcare providers, partners, and persons with lived experience is united by a shared commitment to equitable access to research, innovation, and care for children with cancer and their families in Canada. One of the ways we support these objectives is by hosting free educational sessions throughout the year. These sessions are designed to share updates and insights from a variety of experts in the pediatric cancer space. So today we're excited to have you join us for a session that fits very well with the mandate of ACCESS, and it's going to talk about the cost of traveling for pediatric cancer treatment in the Maritimes. So in Atlantic Canada, more so for this particular project was the Maritimes. There's only one tertiary pediatric oncology center, which is at the IWK in Halifax, Nova Scotia. So as you can imagine, the geographic area is very large. And as a result, many families have to travel very long distances to get to the IWK for care. So in our current study, which is still ongoing, the research team has conducted interviews. That's complete, and the focus groups, which is what we'll speak about today, with families of children diagnosed with cancer who've received treatment at the IWK. And the study really looked, both studies, to better understand the financial and psychosocial needs of these families who have to travel these long distances. So please join us with this educational session to learn more about the challenges families face, the findings emerging from this research, and the opportunities to improve support for families traveling for care. And I'll introduce our speaker today. It's Zara Forberger. So Zara joined the IWK research team as a research assistant in 2016. Where her research interests really have evolved to include the financial burden experienced by families of children with cancer. And she's done a very great job with this research. She has earned a master's degree in pathology from Dalhousie University in 2023 and is currently completing her PhD in pharmacology at Dalhousie, focusing on biomarkers of disease recurrence. So please feel free to send in your questions via the Q&A chat button below throughout the talk. Speakers will be answering audience questions at the end of the session. So I'll now pass it over to Zara.
Thank you for the introduction, Tamara. Like she said, my presentation today is on the cost of traveling for pediatric cancer treatment in the Maritimes. And so I have no conflicts of interest to disclose. So just an overview of how my talk is going to be outlined. Like Tamara said, we conducted 2 studies. The first was one-on-one interviews in 2016 to 2020, and then we conducted focus groups in 2025. And so my talk is going to be outlined by going through the interview study first, and then I'll go through the focus group study. So, the IWK Health is in a unique situation where it treats pediatric cancer patients from the three maritime provinces of Nova Scotia, Prince Edward Island, and New Brunswick. And so there is a shared care model, which means that patients are able to receive chemotherapy at their home hospital whenever it is safe. But however, patients still do have to travel to Halifax, Nova Scotia, and the IWK for treatment. And as you can see by this map, they do have to travel some long distances. So, for example, if you're in New Brunswick and Bathurst, that's almost 5 hours of one way travel just to get to the IWK to treat your child for cancer. So, the reason why this study is necessary is because traveling for cancer treatment results in three main costs to families. The first is direct costs. So, these are out of pocket expenses like fuel, food, and accommodations. There's also indirect costs like time lost to work, as well as household upkeep. And then, as you can imagine, these will have a psychosocial effect, so affecting their quality of life. There can also be stress and anxiety related to having to change your jobs. And this is all on top of having a child diagnosed with cancer. So I'll first go through our interview study. And so the aim of this study was to report on these direct, indirect, and psychosocial costs to families through both quantitative estimations of the money they spent and their time lost at work, as well as the qualitative interview data to capture the impact of these burdens. So for the quantitative analysis, we collected information on the money spent in the first year of treatment when traveling to the IWK. So we received this information from patients themselves. So some families kept a written report of every single expense they had. Some families collected receipts. And then we also filled in some gaps with interview questions. However, not every family provided all of these written expenses, receipts, and interview data. And this is because they were dealing with a child undergoing treatment. And so it was a burden for them sometimes to record all of this information. And so we also did use a cost estimation to fill in the gaps. So through their health records, we had information on their visit history, as well as how far away they lived from the hospital. And so we were able to estimate how much mileage they had, as well as what they spent on fuel and accommodations. So, in terms of the interviews, we conducted 1 to 2 interviews with families. And our first two questions were trying to get at these direct and indirect costs. So, tell me about your spending so far, and has your employment status changed? And then the last two questions were to assess the psychosocial impact. So, how do you feel about the money you're spending due to travel? And has this impacted you financially in other areas? In order to analyze this data, we used a constant comparative technique. So this is where the transcripts are read and coded, then reread and recoded until constant themes emerge. And we used 2 independent researchers to do this, and then we compared the themes that they found until we got a consistent list of 8 themes. So in terms of demographics, 30 participants were enrolled in this study. 28 of them provided financial information, and the other 29 participated in interviews. In terms of their child's diagnosis, we were able to capture many diagnoses with many different treatment protocols. So 37% were leukemia, 27% were other diagnoses, so like Wilms tumor, neuroblastoma, Langerhans cell histiocytosis. Then it was sarcoma and lymphoma for the rest of participants. Also, most of our families, so 21 out of 30, lived more than 100 kilometers away from the IWK. And then 55% of them lived in Nova Scotia, whereas the other 45% either lived in New Brunswick or PEI. So we were able to capture families in all 3 of the provinces. So the first thing we looked at was seeing if distance was related to the out-of-pocket expenses families incurred. So this is a regression plot where the x-axis is the distance from the hospital, and then the y-axis is their total out-of-pocket costs. And as you can see, there is a linear relationship. The R value was 0.7, so distance from hospital was correlated to the out-of-pocket expenses. We then went to see if the total out-of-pocket expenses were significantly different between participants in and out of Nova Scotia. And we actually found that there was not a significantly different distance. And that was because if you think about the geography of the Maritimes, uh, and we pull up this chart that I had on one of the first slides, you can have patients from, for example, Sydney, Nova Scotia, that have to travel around 400 kilometers to get to the IWK. And maybe somebody on the border of New Brunswick would be traveling 266 kilometers. So it really wasn't related to what province they were in terms of cost. It was how far they had to travel for treatment. So, like I said, 8 qualitative themes emerged. And so I'm going to walk you through each one of these themes and provide you with some direct quotes from families because I think it's really important for you to hear their thoughts and their words directly. So I'm going to read them all out loud just for accessibility purposes, but please feel free to read them in your head at your own pace. So, starting with the emotional toll, one participant said, the financial side of it has just been, it's upsetting, it's stressful, it's debilitating. And I like to start with this quote because I just want to get it out of the way right now. Families did find that there was a psychosocial burden and there was an emotional toll relating to the financial side of having to travel for treatment. There was actually 79% of families in our study that described a psychological impact related to expenses. They used terms like stress, experiencing difficulties, worry, frustration, and shock. Another participant said, I've got so much going on, so much on my mind that I can't even really remember words anymore. This once again just highlights the burden that these families are experiencing. Not only are they having a child who's been diagnosed with cancer, they now also have to deal with this financial side of things and having to worry about money getting their child to the hospital for treatment. Our next theme is direct costs. So these are things like fuel, food, hotels, and tolls. So some participants found that fuel was a big cost. So one participant said, fuel is the biggest, the absolute biggest. To get here, we're looking at about $600 to $800 a month. That's just gas to get here so that he can have treatment. So we found that families described costs relating to getting to the IWK as fuel, bridge, tolls, parking, and vehicle maintenance. And so, like this participant said, that's an additional $600 to $800 a month just in gas to get to the IWK. That's a big additional cost these families are experiencing. And so, when we calculated the median mileage costs in the first year of treatment, we found that families were spending around $4,600 to get to the IWK. And so, these mileage costs are including not only fuel, but wear and tear on the vehicle. And as you'll see as I'm going through these slides, I'm reporting the interquartile range. So this is what the middle 50% of families were experiencing. So you can see that the middle 50% was actually incurring costs of $3,500 to $6,500 in the first year just on mileage. Other families found that food was a huge cost. So one participant said, the majority of our money was spent with food. When you have a child that's in treatment, it's really difficult to stimulate an appetite to begin with. So it was very quick that the food from the cafeteria became something that she just couldn't bring herself to eat. So families spent a median of $2,700 on food coming to the IWK in the first year of treatment. So when a child is admitted to inpatient, for example, their meals are covered at the IWK if they use the Dial for Dining service. But no child is allowed in the hospital without a caregiver, and the caregiver's food is not covered. Additionally, like this participant mentioned, a lot of children got tired and sick of eating the cafeteria food, and that meant that families had to rely on more expensive options to feed their child. So in our study, families relied on meal prepping food, restaurants, as well as the IWK cafeteria. And we found that most expenses occurred in the first 6 months of treatment. We also found that 55% of participants in our family reported spending money on accommodations. So the median cost in the first year was $136. But if you look at the interquartile range, there were families that spent $0 on accommodations in the first year, probably because they live quite close to the hospital. But then other families were having to spend around $1,200. So participants did have access to the Ronald McDonald House, which is $11 a night. But when you're constantly staying at it, that does quickly add up. And that's something participants mentioned. Additionally, it wasn't always available to them, and they sometimes had to rely on hotels. And then they're looking at around $150 a night just to find some accommodations. So in total, we found that families spent an average of $9,600 on direct costs in the first year of treatment. So this is a substantial amount of additional money these families are having to worry about covering just to get their child to the hospital for treatment. The next is indirect costs. And for this one, I'm going to be talking a lot about employment insurance for caregivers. So employment insurance covers up to 55% of your income for 35 weeks. And one participant, when talking about it, said, "It's not really fair that the only benefit you can get is if you've been working full time for a year before they got sick, because you don't plan for this kind of stuff, right? It's really, really frustrating." That's the biggest emotion I have with all of this. So, EI, the expectation with EI is that it will be there and available to help families when they're unable to work. But EI benefits are only a maximum of 55% of your earnings. And if your income exceeds that maximum, you may actually be experiencing a greater reduction in your costs, in your income. Additionally, it only lasts 35 weeks. And so, as you know, for pediatric cancer treatment, some protocols can last a year or multiple years. And so, families didn't find that not only did it recover enough of their income, it also didn't last long enough. And as this participant mentioned, there's also circumstances when EI is not available. So, summer months for teachers, or mothers who were on maternity leave prior to their child's diagnosis, or if they were already on EI prior to diagnosis. Because, like this family said, you don't plan for this kind of stuff. And so EI just might not be an option for some families. Another participant said, "Because I am self-employed, I don't have the luxury of unemployment or sick benefits or, mental health benefits. I don't have that option." So this is just highlighting another group of individuals who may be more vulnerable, which is families who have self-employment. Because not only can they not get unemployment, they also don't have the mental health benefits to help with the psychosocial toll that their child being diagnosed with cancer and this financial burden is causing. So we found that 71% of families experience some loss of wage. In a lot of cases, families consumed their sick leave, their vacation time, employment insurance for caregivers, and then eventually they had to just go without income. So in our study, there was a median of 55 days of work missed during the first year of treatment. So that's almost 2 months, 17% of their income has been reduced in the first year. Additionally, you can see that there was when we look at the range, there was some families that didn't have to miss any work, and there was some families that missed 346 days of work. And you may be thinking, well, there's only 250 days of paid work during a year. But in a lot of cases, or in some cases, both parents ended up taking time off. And this is because they wanted to spend time with their sick child. And so not only do they have increased direct costs, so they're paying more out of pocket, they're also experiencing a loss of wage. And so you can imagine this is just compounding the issue. Our next theme is the reality of government assistance. One participant said, "That perception of universal health care, it doesn't cost anything for health care in Canada. We're living the fact that that's not entirely true." And I thought this was a really great quote to summarize how families felt about government assistance. We always hear about universal health care, but there's all of these extra costs that families don't expect. Medications aren't fully covered. They have all of these direct costs for travel. And then additionally, there's things like a thermometer that families will have to pay for that isn't covered, so that they can get an accurate reading of their child's temperature. And that's an additional $100. So families felt that the government assistance was not enough to help them. Another participant said, "We've tried to record what we're spending for purposes of income tax, and that's kind of disappointing that we don't get a better discount or better deduction." So 24% of families mentioned using income tax as a way to capture their travel expenses. And a lot of them didn't even realize how much money they were spending until the end of year when they had to write down all of their hospital visits and checks. Additionally, a lot of families felt that the amount of tax return they received was not enough to substantially recover the amount of money they were spending on direct costs. And so the income tax was another disappointment for them. Our next theme is hidden costs. So these were costs that families indicated that they weren't anticipating having or weren't told about having. So, for example, a couple families mentioned having to get a new vehicle to travel to the hospital. So, in the next few years, maybe they planned on upgrading their vehicle, but when they found that their child was diagnosed with cancer and they were going to have to be doing a lot of travel to get to the IWK, they ended up pushing that expense up, even though they weren't necessarily ready to spend that money. Additionally, families had to pay for distractions for kids on the way to the hospital as well as in the hospital. A family mentioned having to get a trainer to keep the patient healthy because they weren't able to do the regular exercise that they were used to. And so these costs are coming at a time when the family's income and budget is already stretched to its limit, and now they're having these hidden costs pop up. So, another theme that came out was receiving help. So, one participant said, "We had some fundraisers at our school and stuff. I don't know what we would have done if we hadn't had those. They were huge helps just to stay above water." So, 76% of participants reported receiving help. So, 38% mentioned social workers getting help with meal cards, parking, and gas cards. 52% received help from families and friends, and 28% mentioned community help. But the issue with this is that it's not standardized, and not every family is going to be receiving the exact same support. And this is really highlighted with our next theme, which is no help. One family said, "I don't know how we're ever going to get out of the hole that we're in. There's no help for us. There's zero help for us." 21% of participants in our study indicated that they had no help. And so, because it's not standardized, these participants fall through the cracks and they feel like there's no way that they can get out of that hole that they're in. Another participant said, "I'm more upset at how hard you have to work to get help, or how many walls you have to knock down in order to find the help, or when they say, 'No, sorry, can't help.'" So not only is it an issue with some participants not receiving help, it's also an additional burden trying to get the help that they're required or able to receive. And it's especially frustrating when they knock down all of these walls, go through all of these barriers, just to be told in the end that there is no help for them. Our last theme is fortunate. So, one participant said, "We're pretty fortunate in the sense that we both are professionals with good incomes, and so we're perhaps more able to absorb the impact of the financial hit than others." So, this theme was shocking to me. After everything that I've already talked about, 82% of participants expressed a feeling of luck or fortune for their situation. And these terms were actually used 100 times by participants in appreciation for their jobs, families, home, vehicle, health plan, accommodations, and community support. And so this really goes to show the resilience of these families. Despite everything that they're going through, they're still able to find something that they're fortunate for or something that they're lucky. Um, and I think it's important to note that when a lot of families expressed this feeling of luck or fortune, they were very quick to say that not all families would be as lucky or fortunate or have the exact same experience that they're having. And so, once again, it's really important to try to find something that's standardized so that all families can have the same amount of support. So, in conclusion, for our interviews, we found that there is a substantial burden due to traveling for treatment, and this is both financial and emotional. And through these interviews, we came up with two additional questions. So, what do families think could help? And how does this impact clinical trial participation? Which led us to our focus group studies, which was in 2025. So we conducted focus groups with 4 questions. So our first 2 questions were trying to get at those direct, indirect, and psychosocial burdens, just because it had been about 5 years since we asked families these questions, and we wanted to check in to see if the same issues were still there. Then we had our third question where we wanted to see if these burdens would impact their decision to participate in clinical trials, with a clarification that if the clinical trial resulted in more trips to the hospital, would that impact their decision? And then finally, we wanted to ask participants, what do they think could help? Again, we used a constant comparative technique. So the transcripts were read and reread and coded, reread and recoded until constant themes emerged. And again, we used 2 individual researchers and compared the themes that they found. So for the focus groups, we conducted 4 of them from May to June of 2025. There were 2 to 5 participants in each focus group. So we spoke to a total of 13 families. So in terms of qualitative themes, 4 of the themes from our interview study also came out in the focus groups. So families were still experiencing direct costs, so fuel, food, accommodations, they were still an issue. They were still upset by the EI insurance and what they were receiving for that, the amount of time they were losing at work, and they were still experiencing emotional toll due to these costs. Additionally, families were still upset about the amount of government assistance they were experiencing. We also had 4 new themes come out. And so, one of the good things about focus groups is that it's a group discussion. So, we ask open ended questions, and then participants can talk to each other. And then sometimes we end up with themes that we didn't get or wouldn't have gotten through an interview. So, we ended up with the themes family dynamics and financial vulnerability. And then we also got the themes clinical trials and resource navigation based off of those third and fourth questions we asked. So, in terms of financial vulnerability, one participant said, "You're not working, but you still have the same bills. So, you're getting what, 55% of your wages and still have 100% of your bills?" So, this is hitting on the financial vulnerability that patients are experiencing. Like they said, your wages are going down, but you still have all of your bills, and now you have these direct costs on top of it. And we think that this theme really emerged in the focus groups because participants were speaking to each other and they felt more comfortable to talk about the vulnerability. Additionally, some participants expressed that being able to talk in this focus group made them feel like they were less alone and that other people were experiencing the same things that they were. So I'm going to report some numbers for the focus group, but with focus groups, I'm only reporting on the number of patients or participants that spoke directly. This isn't capturing the ones that were nodding their heads in agreement. And so the numbers might seem smaller, but just keep in mind that this is just directly from the transcripts. So we found that 38% of participants, so 5 of them, spoke about their financial vulnerability. There was one participant who mentioned that they did not feel vulnerable. And the main reason for this was that they had their job in the Canadian Forces and they felt really well supported. So this is potentially a job that we could look at to see what their support system is like and see how we could mirror that for other families. The next theme is family dynamics. So one participant said, getting through a relationship while you're navigating this is extremely difficult because it adds so much stress to your family dynamic and your relationship, both emotionally and financially. So I think this is an important theme that once again probably didn't come out of the interviews because this happened due to participants speaking with each other, was this feeling of family dynamics being affected. So not only is there going to be stress and strain on the partners, the parents, there's also going to be the children, both with cancer and without cancer, who are going to be experiencing a quality of life shift. Additionally, a lot of families ended up relying on relatives to help support them financially, which will once again add in some stress and strain on those relationships. So we found 5 participants spoke about their family dynamics being affected. And it was once again that one participant who had a job in the Canadian Forces that did not have any changes to their family dynamics and is a good case for us to look at and see what their support system is like. Our next theme is clinical trials. So one participant said, I can't see us refusing if you're desperate and it's the life of your child that's going to come above all else. We would basically risk everything. So this was the thought that most participants had, that it didn't matter if it was going to financially ruin them. If it meant that their child was going to have a higher chance of surviving, they would participate in the clinical trial because you can't put a price on your child's life. Another family said, just because all the research on the medication that I did, I'm like, I really want him to get this med. So let's do it and think about the aftermath later. And so I think this quote hits on the fact that these families are kind of in a time crunch. Their child is diagnosed with cancer, and they have to quickly make decisions on what trials and what treatment their child should receive. And so they don't really have time to think about the financial consequences. So families are at a pretty vulnerable state when trying to decide about clinical trial participation because, like most families said, they're going to participate in the trial, even if it financially ruins them, if it's going to save their child's life. So in our study, none of our participants actually participated in a clinical trial, but none of them stated they would refuse a clinical trial due to finances if it would improve their child's outcome. The last theme is resource navigation. So one family said it would depend on, I guess, who your social worker was or your oncology nurse was. Sometimes you'd get a $20 gift card, sometimes you'd get $70. And so this quote is talking about gas cards that participants would receive in order to travel to and from the IWK. And this quote kind of hits on how the perception of families is actually kind of different than the reality. It's not dependent on who your social worker and your oncology nurse is. It actually has more to do with the funds that are available. So these gift cards are based from donations and charity. And so sometimes they have less money, so you're only going to get $20. And also, there are times when the money runs out, so you're not going to get any gift card. So 85% of participants discussed their family care coordinators, social workers, or navigators, and 62% said they had access to one or more of them. And of those, 3 expressed frustrations about accessibility. And then another 3 participants said that they did not have access to the resources. Another participant said it wasn't accessible enough. Half the time, we wouldn't even have time to find the social worker or to get a hold of them, so we would leave without even having had a chance to get any of those opportunities. So not only is it an issue with the amount of money we have available to help these families, it's also how accessible it is. So a lot of times when families come to the IWK, they have multiple appointments with multiple providers. They have to see like psychologist, nutrition, their doctor, the nurse. Sometimes they have to go get scans in another department. And so getting access to those gift cards and the support systems was a struggle for families. One participant had a potential solution. They said, I really think that every family should be assigned a patient advocate or like a patient coordinator kind of thing. And so a couple participants in our study actually did have a patient advocate with them once or twice. And they said it was really helpful just to have them sit with them, explain the treatment, and also help them talk through what resources are available. And so this is something that could potentially help families when trying to navigate all of our resources. So, in conclusion, we found that not only is there an increase in direct costs that families are spending, there's also a loss of income. And this leads to an emotional toll that families are experiencing financially, which is incurring on top of having a child diagnosed with cancer. We found that clinical trials may increase patients' financial vulnerability because no family is going to say no to a clinical trial if it's going to increase their child's chance of surviving, even if it financially ruins them. We found that resource navigation improvements can be made to help families. And kind of the most upsetting thing is that costs are only rising. So, as you have all probably noticed, the cost of fuel and food is going up. And so, the impact that this is having on these families is also just getting worse and worse. In terms of action items, we think we need sustainable, equitable, and consistent travel assistance programs. There also should be more employment protections and access to longer employment insurance benefits. And we need to work on better ways for participants and patients to navigate resources. So, in terms of next steps, we're going to continue speaking about these burdens, continue voicing the thoughts and opinions of these families so that hopefully we can get the word out and change can be made. Additionally, we're starting a new study called the Interprovincial Care for Children Study, where we're going to be conducting semi-structured interviews with healthcare professionals, but also mainly with health system officials. So people who know the legislations and policies so that we can identify where the gaps are and what support systems we can improve on to help participants in the Maritimes and families in the Maritime provinces. And so I would like to thank the research study team members, Dr. Tamara McDonald and Dr. Derek McDonald, as well as our funding agencies for these two studies. And I can take any questions now.
Thank you, Zara, for the wonderful talk. I especially liked you highlighting the themes that came out of the interviews and the focus groups and connecting them directly with the patient and family codes. I think that it really put things into perspective. There are a few questions already coming in, but like Zara mentioned, feel free to type them in to the Q&A box and I'll start reading them out. So your first question is asking if the study has been published or if there's plans for it to be published.
So the interview study, we just got notice yesterday that it is going to be published, and we're just finalizing the focus group manuscript right now.
Great, thank you. And do you know of any specific journals that you're going to be submitting to?
Tamara, what was the name? Cancer Care, I think, is the interview one. And then I don't know what we're thinking for focus groups.
So it's cancer control for the interview study, yeah. So, and we're still looking into the focus group study. So, yeah, you should see it. It should be open access, hopefully shortly.
Great. We look forward to it. So our next question is asking if it's possible to comment a little bit about the model of care that is provided at IWK, whereby if patients have specific case or registered nurse managers or patient advocates, and if yes, what is it?
Tamara, do you want to?
Sure. Yeah. So we have family care coordinators who have their a number of patients on each of their caseloads. So they basically coordinate care. They're the first people that these families reach out to. And then we now have a new position, a navigator position that was created in the past year, which has been very helpful. And I think that's what's come out of this sort of data is to say that, these families really do need somebody to advocate for them. And I think the patient navigator is that person who meets with them on a more regular basis than the social workers can. So, and they also know where all the resources are so they can lead them in the right direction. So that's what we have currently, our structure at the IWK.
Perfect. Our next question is, if any families specifically comment on costs and burdens of having prescriptions filled other than the total cost associated with it. And do most patients have their prescriptions filled at a tertiary site or closer to home?
So we didn't ask specifically about medications in the study. We were trying to hit on travel costs, but despite that, families spoke about their medication costs. And it was a burden. A lot of participants found that they were spending a lot of money, not only on medications, but the syringes, the cleaning materials to be able to administer the medications. Um, in terms of getting it filled, Tamara, you might be better to answer these
Yeah,
questions.
so we don't have a centralized pharmacy at the IWK, so we really don't have an outpatient pharmacy per se. So we really do send them mostly to their home pharmacies in their communities around the Maritimes, which is quite challenging. But we work very closely with those outside pharmacies to try to support these families. So that's our setup here at the moment.
Yes, our next question is regarding support programs available via either community organizations, although it could vary by region or province. They're curious to know if families mentioned any specific support programs that they have accessed that they found helpful and would recommend to other families.
Yeah, so a few came up. There's one that has lions in the name. I don't remember if you remember the exact name, Tamara. That came up a few times. The Irving gas cards were mentioned quite a bit as being helpful.
Mm-hmm.
And those are the main ones that I can remember.
Yeah, I think it's a Lions Club, but I think there are some certain communities have abilities for fundraising support, but there's nothing that's consistent or transferable across all of these regions, and it's really based on the fundraising potential of the areas. I would say that they're quite successful in a lot of the cases, but it certainly doesn't cover all of their expenses either. So this is really part of why we're doing this, is to sort of try to determine if there's something more consistent that we can come up with versus these pockets that are sometimes there and sometimes not.
So another question, were there any suggestions that came from perhaps the families on how the healthcare systems or their employers could help caregivers and children undergoing cancer treatment?
Yeah, so a lot of families had some suggestions. So, um, the 35 weeks for employment insurance, a lot of families felt like that just wasn't enough. So, having employment insurance for a longer time. Um, Additionally, one participant mentioned it would be helpful if the caregiver's food was covered while they were in the hospital, because it's an additional thing that they have to worry about is how they're going to get food for themselves, and it's an additional cost rather than just focusing on caring for their child. The resource navigation, like we talked about, was a big one. Um, Any other big ones? Those are the main ones that are coming to my head right now.
Um, one, I can see some questions coming in. Just give me a second. Um, when you spoke about the self-employed families, were there any supports or suggestions from the self-employed families that indicated what they would like to see out of like an organization or the government to help in their cases?
Mm. Yeah, I think the participants, they had no income coming in. And due to the nature of their job, they weren't able to restart their job for a long period of time due to it put their child at risk for infection because they would have people coming into their home. And so just having income assistance, I think, would have been huge for those families.
Yeah. Um, the next question. So we're getting a lot of comments about how wonderful your talk is, and some groups that are indicating that they would love to collaborate and or reach out to you specifically and your team, perhaps after the talk about further discussions and other services that um, they may be able to either connect your group to and or potentially provide information on. I'm happy to share all of that information after the talk. These are one of the things we like to do with the Access Presents is to foster relationships and collaboration. So thank you for the share. I will definitely pass that on to the to Zara and Tamara. Let's see. And would you be able to touch a little bit on grants that are currently available for both the employed and self-employed families that could that experience income disruptions during treatment?
The grants.
Grants or like a subsidies.
So I actually haven't heard of anything, and I haven't heard of any participants in either of our studies accessing those. It was really employment insurance or long-term disability that families used. So I'm honestly not sure what is available. That's something to look into.
Mhm.
Yeah, I would say we would have heard. I don't know of any either, so I don't know if that's something that's, realistically available for these families.
Okay. So it looks like we've gotten through the list of questions. Um, If anyone else has any comments or further questions, please type it in the Q&A. If not, we can wrap up today's session. I'm happy to provide Azar and Tamara the context that I was saying that came through. Also, the talk will be available on the Access website. And as we mentioned at the beginning of the talk, we do have a survey, which I'll just drop it in the chat. And I will also be emailing it to everyone after the talk for you guys to fill out. Oh, a question did just come in. So, are there cases where a child would need to travel to Quebec or Toronto for clinical trials?
For clinical trials,
From, I guess, I'm assuming it's from the
mm,
Maritimes.
Yeah,
I've heard in our study for transplants having to travel, but Tamara, do you know of clinical trial travel?
there's other options to travel to. You know, certainly if they're French speaking, we try to keep them within the Quebec area, and if not, then to Toronto for sure. We do have families that travel back and forth for clinical trials. Yes.
We have a lot of thank yous and very appreciated. A lot of speakers are very appreciative of your talk. But I think we're at the end of our questions, so we can wrap up for now. Oh, wait. So also again, groups are very happy to share services in particular regions, and so I will provide those notes to you as well.
Perfect.
All right. Thank you so much for your time today.